I'm Trafford Simpson from the Department of from the School of Optometry, and I was asked just to introduce the role that optometry and the Institute of Health Informatics has, Health Informatics Research has, and it probably would start something along the lines of sort of an old bumper sticker which I saw, which would go something along the lines of 2 years ago I couldn't spell health informatics, and now I are one, and the role that health informatics has played in optometry is sort of very new. It was spearheaded by Dominic, and it's really tremendous to have him involved in the department and encouraging us left, right, and center, especially those who didn't really realize perhaps the kind of health informatics work that we were doing, and we really appreciate him sort of showing us and guiding us, and these kinds of seminars have really helped us a lot. And then Paul Stoley, who's a Graham Trust Chair in Health Informatics, who's a recent person in the Department of Optometry, is also showing us, again, some interesting new realms that we can sort of venture into. And then there are a few of us who are in the department who now are learning that we're doing health informatics research, and Marlee would be one of them. So again, it's really great for us in the Department of Optometry to be involved in the Institute of Health Informatics Research, and we'd just like to thank Dominic for that.
Thanks. Good afternoon, everyone. It's my pleasure to introduce our guest speaker today, Dr. Marlee Spafford. She's a professor at the School of Optometry, University of Waterloo. She has been a fellow of the American Academy of Optometry since 1994. Dr. Spafford's research interests include healthcare professional education and socialization, professional gatekeeping, and equity in professional education. Dr. Spafford has received 6 awards for her teaching contributions in areas such as clinical techniques, case analysis, professionalization, and patient care delivery. She will talk today about the searching for implicit amid the explicit and novice case presentations, implications for electronic records. Welcome, Dr. Spafford.
Thank you. Thank you. Thanks very much. I'm part of a research collective called the Interdisciplinary Healthcare Communication Research Collective. And it's headed by Catherine Shire from the Department of English, Literature, and Language. And she's joined by Lorelei Lingard at the Wilson Center for Research and Education, and me. And these are actual images from a recent research meeting that we had. We don't work in a vacuum. We work with others, and we're very fortunate to work with some collaborators that are experts in their respective professions, but also have research interests in the education of clinical novices. We've also had the good fortune to work with a series of impressive research graduate students and undergraduates. Our project is called The Role of Situated Language Practices in Clinical Education Settings. Now, a situated language practice, an example of that is the case presentation. It's a communication tool widely used by healthcare professionals for disseminating patient information. A practitioner examines a patient, and then they need to describe what they've learned to another practitioner. So it's an oral delivery of information. Now, there's a classic structure to the case presentation that's used in a number of professions. It begins with the chief complaint, why is the patient presenting, and continues on with not the entire history, but selected parts of the history that are relevant to the presentation of that patient. History of present illness, past history, the family history, social history, results from the examination, and it culminates in a diagnostic impression, including a plan for action. Clearly, on the surface, the role of the case presentation is to communicate patient facts, but research has shown that it is a powerful influencer to the listener's attitudes and actions regarding the production and protection of scientific objectivity, professional socialization, and regulatory reinforcement within professional communities. We're particularly interested in the novice case presentation, where we have students in healthcare professions who are learning the art of case presentations. So the participants are a student presenter who's examined the patient, is now sharing their information with another healthcare professional who is a clinical expert and is their evaluator, their instructor. There might also be other people present, other students, people farther along in their training, like residents or fellows, that either observe and or participate in that novice case presentation. What is quickly clear in these presentations is there's a dual role occurring. There's one of patient care, but there's one of student education. So our group is interested in questions like, how does the case presentation affect the socialization of health professionals? How does it uniquely affect novice health professionals? How does it start constructing roles? And are there tacit or contradictory messages delivered during the case presentation? I'm not going to actually spend time on the theoretical framework, but I did want to touch to give you an idea of what kinds of theories we've found useful to inform us. Genre theory, structuration theory, rhetorical and discourse analysis have all helped us to start to see the novice case presentation as a genre. I think we often think of genres as forms of art. We use that term frequently, jazz, science fiction. But we view the case presentation as a genre because it's a collection, genres are collections of improvisational strategies. There's flexibility, there's organization, and that collection of strategies that emerges when an individual and their socialization interacts with an organization or a field or a profession. So the novice case presentation, which at the same time as there's student education going on, there's patient care, we note that those dual roles aren't always complementary. Picture the student who is trying to look after their patient to the best of their ability, realizes they don't know something, and the logical course would be to ask their instructor. But they're going to be evaluated, and if they own that lack of knowledge or skill, their evaluation could be lowered. And so they find themselves in a struggle between wanting to provide good care and wanting to be a good student. The novice case presentation provides opportunities to learn ways of knowing, ways of behaving, and some of them are regulated and some of them are regularized. And when we say regulated, we mean very rule-bound, externally controlled. For example, professional colleges set rules like scopes of practice of what a given professional can do. But there's also, and what interests us, is the regularized ways of knowing. These are things that occur when you're embedded in the organization. You start learning there are certain things you have to know and do, and they're not so explicitly stated and rule-bound. So clearly, we see the novice case presentation as a genre, one where there's improvisational strategies that the participants use to mutually negotiate their way through time and space. Now, I'm spending my time today talking to you about case presentations and oral discourse. And perhaps some of you might have more of an interest around written, electronic patient records. And are there connections between what we see as some kind of a written form and the dialogue that happens? And we would suggest yes. One of the things we noticed in our study of optometry students in a clinical setting was that the users, they don't fill the forms in order. They know that page 1, and it's a 4-page form the students use, page 1 gets filled in, then page 3, then page 2, then page 4. An outsider would see that as an odd thing, and yet there's a relationship between the record and the person, and they know the dance they have to go through. We also noticed that the users of the form don't fill everything out. There's gaps. And that's because there's certain database that is collected on all patients, and then there's certain problem-specific data that's collected on certain patients. I don't test color vision in all the patients that I work with, but I would sometimes. And so somehow the users know which part of the record they're to tap into. We also noticed that in optometry novice case presentations, that the record was front and center in the oral discourse. So we have a written discourse, and it's being looked at and talked about at the same time they're talking about the patient. We didn't see that among medical students. The medical record was off to the side to be known about, but not to be used in a novice case presentation. So we have this record, and this is an example of one of the 4 pages from an optometry novice record. And we have somebody who developed this record, and we have somebody who uses this record. And we would suggest that there's a lot of interactions going on. There are interactions within the record between things like titles and the sections that are dictating its use. And there are interactions clearly between the person who developed this record, and they have not worked in a vacuum. They've had to talk to users and see how they need to use the record. And of course, the influence that the user has on the record and the record has on the user. So when there's this many interactions going on, we see this as a powerful socializing tool, the written record, like we see the oral presentation of the case record. So I'm going to go back to talking about novice case presentations. And we conducted 3 case studies. We observed novice case presentations occurring in a clinical setting. We looked at medical students, optometry students, and social work students. What we did is we audio recorded those novice case presentations and then took those audio records and transcribed them, meaning we typed out everything that was said. We also interviewed people. We interviewed students. We interviewed the instructors afterward and got their ideas of what was a good case presentation and what wasn't. How did they learn how to do the acts of a case presentation. And then we collected relevant documents. For example, what were the educational objectives of that rotation? What were the written records? What did they look like? Now, we did both quantitative and qualitative analysis. The bulk of our analysis is qualitative. In terms of quantitative, sometimes we were doing descriptive statistics, the frequencies of certain instances of behaviors we'd notice. And at times, depending on our research question, we would do statistical analysis. It might be the greenhouse geyser if it was a parametric requiring a test, or sometimes we did non-parametric tests. The bulk of our time we spent doing qualitative methods, and the main test or method we relied on was the grounded theory method. And that is an inductive method where the theory actually emerges from the data. We would separately in our group read the transcripts from the case presentations and start to identify emerging themes. Then we compare with each other. Did we start to see some of the same themes? And did we see them not just in 1 or 2 transcripts, but across the transcripts and more than once in a transcript? So that repeated themes. And that helped us to apply and refine and confirm those themes. It's an iterative process, and it helps ensure that the constructs that we come up with actually are reflected in the data. So we did those different types of methodologies, and I'm going to today focus on optometry and medicine, and not the social work data. When we analyzed our data, we started to see some certain major themes in case presentations, certain moves or strategies. We noticed that there were certain strategies specific of case presentations, order, how the case presentation proceeded. There were certain teaching strategies that instructors invoked. There were certain times when the student clearly was a student. They're trying to look after a patient, but they have to be in a mindset to survive the educational experience. And there were times when you saw the doc thinking and modeling behavior of what it's like to be a full-fledged healthcare professional. And then there were times what we identified as identity formation, things that powerful socialization moments for the student and the instructor. And I'm going to come back to some of those themes as we go along. Just want to do a little comparison between the medical side and the optometry side. We were observing third-year students about halfway through their training program, and they're called clerks when they're in a clinical setting. And they happen to be in their pediatrics rotation at the time. The optometry students were at the beginning of their 4th year, both programs being 4-year professional programs, and they're called interns when they're in clinic. And they happen to be in the primary care rotation, which is where sort of the routine eye exam that you're all familiar with is completed. The medical site happened at a teaching urban hospital, so the patients were inpatients, meaning they were admitted already. They weren't going anywhere. And so that creates a certain leisureliness about the case presentation because there isn't a patient waiting to leave. Whereas in optometry, patients are outpatients. They are waiting in a room. When the student steps away from the exam and they talk to the instructor, there is a patient waiting. And they would like this case presentation not to take a long, long time. So we tended to notice that case presentations in the medical site tended to be 20, 30 minutes long, whereas they were more like 5 and 15 minutes long in optometry. We observed 16 case presentations in the medical site. 21 interviews were conducted of 11 students and 10 physicians, specifically pediatricians. One of the things we did is we took some of the data, the observations, the transcripts, and we decided here's one that seems like a more sophisticated case presentation, here's one that seems less. And then we hired actors to play out those little vignettes from the data. And then we showed them in the interviews and allowed the participants to say which ones they liked more and less, what they liked about them and not. It was a really useful tool for them to start saying, yeah, that's what I really like about a case presentation. This is what I don't like. In the optometry, we recorded 31 case presentations, conducted 8 interviews, 4 students, 4 optometrists. And we didn't do this in a video clip, but we did it as an audio clip of the data, optometry data, sophisticated, less sophisticated, and let the participants comment on those. Now, at the time of the study, the at the medical site, the case presentation structure was actually taught. The one I talked about earlier was very formalized in the curriculum, whereas in optometry, it wasn't. It now is. But at the time, students learned how to present cases kind of on the fly by what docs said to them in the case presentation or during their case presentations. Interesting, in the medical environment, the patient record was to be known by the student but not used. And if they wanted to refer to their record, they were penalized. The comments were made to them about, you shouldn't have to go to your record to know that. And the students tended to assess their patient, a child or infant, on one day and present to their attending pediatrician the next day so they had a chance to practice their case presentation, typically with a resident. And the relationship was that within the case presentation, it was a one-to-one, meaning the student and the instructor don't have other agendas of time commitments going on. Whereas over in optometry, the student can't practice because they're walking right out of an eye exam and right up to their instructor. And so they don't get a chance to practice. And they have their record. They're just still filling out the record as they're walking up to their instructor. So the record is pivotal in the exchange. And in the primary care unit, the typical instructor-student ratio is 4-to-1. So you have the instructor always aware that there's another student about to queue up to do a case presentation. The data in some ways is similar. There's terminology in the discussion, there's measurements for both, but optometrists, being those visual people that they are, they like to draw pictures. And so they draw pictures of what they see in the eye, outside the eye. Now, I suggested in my title that we're interested in explicit versus implicit. And just to be clear, I mean explicit is a clear and detailed message. Not too much room for confusion. Whereas in implicit messages, it's more implied. It's not directly expressed. And the opportunities for misconstruing the message are greater. This is not to say that a student couldn't misconstrue an explicit message. The data that I'm going to present to you, I've divided into 3 sections. 2 of them, analysis we've done in the optometry case study, and 1 in the medical. And the first one I'm going to talk to you about is what we've called tensions in the field, teaching standards of practice in optometry case presentations. What we did is we were interested in, we started to notice that there were messages, teachings that the instructors gave to students about standards of practice, what was the right thing to be doing. And what we observed is that we could put those instances in 3 different categories, one of them being the official way. And that occurred when the optometrist taught regulations and guidelines that are set outside the institution. So this could be professional guidelines, like a professional college sets it, or the government, or the literature. And we noticed 14 instances of the official teaching by the official way. We also noticed our way, 16 instances where the optometrist taught more institutional rules and approach. This optometry site observations occurred in a teaching optometry clinic associated with an optometry school. I'm not telling you which one, it's a secret. My way, this was the most prevalent way that standards of practice were taught, twice as often as the other 2 instances, where optometrists taught their personal approach. Now, it's not to say that their personal approach wasn't in line with official ways or institutional, but the way they presented is I think, I do, I believe. I'm just going to give you one excerpt that matches each of those categories to give you a feel for it. This is an excerpt for official way from Optometrist 3. No, it's 6 weeks. That's what the textbooks say. If you go through the first 6 to 8 weeks, 6 weeks especially, without having a retinal break happening, you're probably okay. So here we see a reference to literature that the rationale behind saying this period of time is from some kind of external source. Our way. Remember, this is more institutionally based. Optometrist 1 says, so there are a list of indications, specific indications for pupil dilation in your procedures manual. Now, this procedures manual is written by the faculty at the optometry school, and students must buy it, and they must learn how to do the various procedures that make up an eye examination. If you went to another optometry school, some of those procedures might be taught differently. So it becomes a very institutional mindset of how to do these procedures. Here's an example from my way. I based that judgment on how definite it seemed to be when you were testing. You know, with the cross-sill. If it seemed wishy-washy, so that you're not sure if the cylinder's there or not, then I'm inclined to take it out. I base that judgment. I'm inclined to take it out. That sense of, that's that person's personal rationale. It may be a very logical rationale, and I'm not questioning it, but it's delivered as, this is what I do. And the difficulty is, will the student know that that's not just the idiosyncratic approach of that doctor? That's the question. Now, if we were to try to think of the relationship between teaching standards of practice between the official and the our and the my way, one model might be what we could call the containment model, that the my way kind of flows from the our way and flows from the bigger master plan of the official way, that everything's in keeping. Anything the doc says is exactly in line with. An alternative model would be the overlapping model, where if we talk about the my way, it often is in keeping or in synchrony with the our way and the official way, but not always. Yes, Dan?
I would have expected a containment model, but with the red in the center, yellow in the middle, and the blue in the outside.
I see.
Because
yes.
A doctor gets experience that goes beyond what is taught.
That's a really interesting model, that one could assume that. It's interesting that we can think of it as that the field is the all-knowing and the person is a subset of that, but you've just framed it in also a very interesting way.
So you didn't find that at all?
No, actually what we found, and nice segue, is that our data kind of modeled more the overlapping. That there were times when they were in synchrony, but times they weren't. And we hadn't even considered your idea, which I think is also a very interesting way to look at the data. But that's what we found, is our instances really came into supporting a more overlapping model. So when you think about it, it's really an interesting process for the student. They have to learn how to balance 3 different teaching strategies coming at them. And they have to then start making some responsible decisions from those different options, and then develop their professional position. What are they going to do? What's their standard of practice? The teacher is in that interesting juggling act, trying to make sure that patient gets good care, trying to teach the student. So they've got those multiple goals, and they got real time constraints because there's other students waiting for them. So they're trying to figure out how to efficiently get through this series of students. They don't have a luxury of lots of times to spend explaining their rationale. So what we think we see happening is that a lot of the teacher's reasoning around standards of practice is implicit, tacit. They don't take time to say, you know, I do it this way because, and go on to say it. They don't have that time. They just say, I do it this way. I think that. The only problem is the students sometimes were thinking, oh yes, I know when I have Dr. X, I have to do it this way. When I have Dr. Y, I have to do it that way. I'm going to please these individual docs, and that's how I'll survive as a student. They don't think that it's anything beyond idiosyncratic behaviors coming from the docs. And we saw that when we interviewed the students, as they thought that, oh yeah, you just have to please each of the docs, and that's their way. So what we saw that data illustrating was an example, a powerful example of identity formation, that teaching standards of practice was an opportunity for the student to start in the socialization process. How were they going to juggle all of these standards of practice and figure out what they were going to do? The second item I wanted to share with you from our optometry data was what we've called teaching the balancing act, integrating patient and professional agendas in optometry. Here what we're interested in is looking at where does the patient place in all of this. The patient's agenda, like, I want new glasses. I don't want that test done today. Whatever is their agenda, do we talk about it? And do we talk about the professional agenda? Making sure the student knows, well, you must check the health of their eyes and must check the clarity of their vision and the eye coordination. So when are we talking to them about what we have to do to be good optometrists? And when do we talk to them about what the patient wants? So we looked through our transcripts for evidence of those exchanges when either came up. And what we found is there were times the patient agenda was discussed and times when professional agenda. And sometimes those two agendas, they overlapped, and there was compatibility. In other words, patient says, I want new glasses, no problem. We can do all the parts of the eye exam, and we found a change in your glasses. We can make you happy, change your glasses, and we have done all the things we were meant to do. There's compatibility of those agendas. But not all of the time were those agendas compatible. There were times when what the patient wanted wasn't going to fit in with what our responsibilities were that we thought as optometrists. Or for us to do our job, this wasn't going to fit in with what the patient wanted. We noticed certain instances that were compatible, examples of compatible agendas between patient and professional. One of the examples was appointment purpose, where the patient is here for some reason and we can do all of the things we want to do and it works out just fine. Example, patient wants glasses, we can do that for them. Treatment options was another one, where perhaps the patient says, well, I can't believe it, but my arms have gotten shorter, and so I can't manage reading the newspaper anymore. And so we talk to them about the various ways that we could prescribe something so they can see. And we've met the agendas. I'm not sharing specific excerpts of those with you because they tend to be quite protracted, quite long. But there's exchanges back and forth about looking at patient and professional. And one of the things we noticed is that teachers were really good at trying to get the student to keep both in mind. And sometimes what happened is the student had it in mind but wasn't very good at communicating to the doc that the patient had a particular agenda. And it was well into a case presentation before the instructor, who's looking perplexed because they can't figure out why the student's going in this direction until they kind of say, why are we doing this for the patient? And then the student coughs up, oh, because they want this to be done. Oh, that makes sense. And they're both now talking out of the same page. Now, there were also examples, as you would expect, where agendas weren't compatible. And where we saw instances of incompatible agendas was around patient consent and guideline adherence. So patient consent, maybe we're evaluating a patient who has diabetes. And in our opinion, we need to put drops in their eyes, dilate their pupils, and take a very thorough examination of the health tissues in their eye. The patient says, I'm not getting eye drops today. I got a meeting right after now, and I won't have my vision blurred, so I'm not doing it. Our professional agenda is we need to look after their health, and their personal agenda is I either don't have time for it or it doesn't work with my schedule. Now we have incompatible agendas. And how are we going to teach the students what to do when the agendas are incompatible? How to manage that tension. We also noticed it coming around guideline adherence. Patient drives to their eye examination, and we find out during the appointment they no longer meet driving requirements. How are we going to deal with the fact that they would like to continue driving and they no longer meet that requirement? How are we going to deal with that? So we imagine situations, we know they're there, where professional and patient agendas are not compatible. So what would be a teaching strategy for saying to the students, how are you going to deal with that? And the one thing that we did notice was that the teacher said, get the patient agenda to move towards yours. That's the strategy. Shift the patient to your position. So the professional agenda is going to stay. We are professionals. This is what we do. So the only solution to this problem is shift the patient. Get them to see it differently. Convince them. Persuade them. That seems like a good strategy, but it does assume one is rigid and one is more fluid and can be moved. Not saying that's wrong, but it's an interesting position, and it's the only strategy that we saw invoked. We asked students about the teaching strategies. How explicit were they? How much did they feel they were directly being told? And this excerpt reflects what other students said. It's quite interesting. Student 5 said, sometimes they'll give you like a puzzled look, like, what are you talking about? And then you know you're barking up the wrong tree. And it's interesting because some clinicians, they know you're going down the wrong path. And they'll let you keep going and going and going. And they'll go with you even though they know you're wrong. You don't know it till you're right at the end, and then you're like, oh, it's brutal. So they talk about the fact that while the doc thinks they're doing good things and teaching them and taking them through Socratic methods and taking them down roads to show them that they're wrong, the students would rather you just, okay, cut me off now, tell me I'm wrong, and let's explicitly discuss what we should be, what's going to work. Around patient and professional agendas, we felt students need help, and we're getting a lot of help around trying to identify what's the patient agenda, what's the professional agenda, trying to learn how to balance these, weigh them, and they were getting certainly some help around developing strategies for managing incompatible agendas. But that we suspect that more explicit instruction would be helpful in this area. We felt this was another example of identity formation, where it's an interesting look into how patient-centered is optometry. Well, we are pretty centered because we talk a lot about the patient's agenda. However, when push comes to shove, when it doesn't match with ours, we will try to move them towards us. This is an interesting difference from medicine, where there were no discussions about patient agenda. It was just the professional agenda. So at least optometry talks about it and tries, but they're not really quite sure when it doesn't match their agendas. The final piece of analysis I wanted to share with you today comes from the medical case study. We've entitled this, Look Who's Talking, Teaching and Learning Through the Genre of Medical Case Presentations. what we were asking was how much of that time in that case presentation was focused on student practice and how much was expert teaching. And do those overlapping activity systems of patient care and student education, do they create any difficulties for the participants, the students, the instructors, in trying to balance those two agendas? And finally, were there tacit messages being conveyed that a more overt teaching strategy might readily identify? Here's where we'll share with you some quantitative as well as qualitative approach. What we did is we took each of the 16 transcripts, the medical transcripts, and we said, let's kind of try to get a sense of airtime of who spoke. And so we literally counted the number of words spoken by the clerks, the students, the pediatricians, and the others in the room. We put all in one little group. And so for a given transcript, how much of the time were those three parties speaking? And then we said it's a bit arbitrary, but we're going to take that transcript and we're going to break it down into 4 time periods, the first quarter, the second, third, and fourth, to see how does that airtime change during the case presentation. You might guess students talk more at the beginning and less, and you'd be very good if you guessed that. We'll be showing you that in a moment. We also said, okay, that's not enough to know about. Let's look at what they're talking about. How much is focused on diagnosis of a problem? How much on management? And how much about talking to the patient, getting the case history, doing the counseling? We also look at educational objectives. For the pediatric rotation, there were 9 educational objectives. How often did we see those educational objectives emerging and being addressed in the case presentation itself? We used in our non-parametric testing the Crisco-Wallace and the Wilcoxon, and in our parametric the Greenhouse Geyser. And we continued to use the grounded theory method in our qualitative assessment. When we looked at the mean airtime across those 16 transcripts, we found that half the time it was the students talking in a transcript, and 43% the docs. And only 8% was the others. And statistically, those others spoke significantly less than the students or the instructors. Yes, Paul? The others were, they could occasionally be medical students, but they were more likely residents and fellows. And that is an interesting point because it will play into who gets involved in discussions as we talk. Yes? Patients participate in this? It's a good question. All these case presentations occur without the patient present, both in optometry and in medicine. So we like to keep our patients separate and talk about them when they're not around.
Pretty much the universal model.
Yes. One might spend a lot of time commentating on that, but. So others spoke significantly less than the students and the docs, and statistically, the students and the instructors did not speak significantly different from each other. Okay, that's a little piece of information. Let's look at this now across, oh my gosh, don't you hate when your presentation goes to the end of the, let's see now, what should I do to get, several. Last viewed, I like that.
The page back.
See, that was good. Thank you. Technology. So let's look across the quartiles. And so blue is represented of the students, and burgundy, instructors and others are in the pale yellow. So across these 4 quartiles, this is from the beginning to the end of the case presentation, what on average happened was that students initially had most of the airtime in the first quartile, over 80%. And as the case presentation flows less and less, till down to about 27% of the conversation in the final quartile. The pediatricians, well, they start around 17, 18%, and they take more and more airtime up to about 60% at the end. The others, they don't say much in the first half, but in the second half, they start venturing into the conversation 12, 13%. So we looked at this statistically, and what we found first is the students significantly talked less as the case presentation went on. The docs talked significantly more, and so did the others. First thing we learned. Second thing we learned is that the profiles, these trends, were significantly different from each other. So we're starting to see a general pattern of who's doing the talking, but in addition now we want to see what are they talking about to get a sense of patient care and student education issues. So I'm going to break it down into the 4 quartiles. In the first quartile, where students are dominating the airtime, what they're doing is presenting the patient information, exactly what you would expect them to be doing. They're describing their assessment of the patient. And what the pediatrician, the teacher, is doing is they really only interject to ask clarification types questions. The student has said that the patient had a flu 3 weeks ago and was treated, but they don't say how they were treated, so the doc jumps in there and says, how were they treated? So they're basically just starting to scaffold the case presentation. And what we mean by that is they're starting to put out little hints to the student. This is some information you should have collected. This is information to tell me. And so they start interjecting. But that's really the bulk of their participation at that point. Here's an example from the first quartile. Student 7 says, about 3 weeks ago, he had pneumonia, which was treated with antibiotics by his family doctor. And the instructor says, do we know what antibiotic it was? No, I don't know what antibiotic it was. No, now associated with illness. So what happened here is the doc identified a missing piece of information, what antibiotic. And the student is unable to resolve this gap. They didn't find that information. The student, though it's not been discussed, just knows, I messed up. I should have found that piece of information out. It's not an explicit message, but they know. In the middle quartiles, the second and third quartiles, we see decreasing airtime by the student. And they're starting, the transmission of the patient information is starting to decline. They're running out of things to say about this patient. Meanwhile, the pediatrician, whose airtime is increasing, they're starting to question more, and they're starting to invoke more and more teaching strategies, going into the data more in depth. What does this mean? What could it mean? And they're doing a lot of this scaffolding, the thoughts of the student around diagnosis and sometimes around treatment. Here's an excerpt from the middle quartiles. Between pediatrician 7 and student 8. Pediatrician, white cell count was 35.8. That was from Emerge. Student, it was from Emerge. Pediatrician, what do you think about that? Student, well, the greater majority were poly 32.6. Physician, Student, so that would point more to a bacterial infection rather than a viral infection. Pediatrician, any other possibilities of what it might represent? Student, well, you would see increased white blood cell count in a lymphoma, in an inflammatory state. Pediatrician, What else could give you a high white count? You see the pediatrician just going at them, question at a time, trying to draw out, because they haven't got the list yet. There's a list of things that could have caused this finding, and they haven't got it, so they'll keep drawing them. It's a Socratic method. The pediatrician knows exactly where we want to end up, and they're going to keep fishing till the student gives them what they want. The final quartile. Here, the student is not speaking as nearly as much. And what's happening over these case presentations, the student goes from care provider, I did this with the patient, I did this with the patient, more to observer role. And the teacher is really dominating the airtime and doing teaching strategies and talking about pet topics. We had one physician who loved to talk about nutrition. Loved it, loved it, loved it. So would use any opportunity to talk about the developmental milestones of nutrition. The teacher is balancing that, patient care and student education. And one of the interesting things that we saw happening is what we call doc talk. Remember these other people? They were often residents and fellows, other physicians in their training process. And what would happen is, towards the end is when we often saw treatment discussions. And the students tended to back away from those conversations, be strictly observers, and the doctors talk to each other about what we're going to do for this patient. And so they're still involved, they're on the peripheral edge of this healthcare team, but they're now observing. And they're taking this in and watching that interplay go. What interests us not only is what on average happens, but what about the outliers? What do they tell us? And here are 4 case presentations. These 2 are where the pediatrician, the teacher, talks a lot more than on average. And these 2 over here, where the student seems to grab all the airtime. What's happening there? So what we noticed was that when pediatricians dominated the airtime, medical complexity of the case was an important role. Both in case presentation 3 and 12, these were medically low complex cases. Children perhaps in for a flu-like problem and not really too hard to sort out. So what would happen is the pediatrician would take the tactic of using that case to teach more broadly. Well, there's not much here to teach about. So let's talk about developmental milestones. Let's talk about newborn reflexes. Let's use this case. Well, it's a 6-month-old. Let's talk about what 6-month-olds can do. Not specifically, in other words, about the patient, but more broadly. So they would have a little teaching lesson. The other thing is we noticed these docs tended to provide more supportive commentary than some of the other pediatricians. Here's an example. Pediatrician 8, I'd just like to make a comment about that because it's a really excellent question you've asked. It takes more airtime to tell students routinely and support them that they are doing a good job. And so that contributed on a more minor level to greater airtime on the part of the pediatricians. But in the presence of low complexity, the pediatricians talked about other things. What about when the students dominated the airtime? Well, one of these examples, CP12, case presentation 11, where the student absolutely hogged the airtime, was an example where the case presentation was very medically complex. An 11-year-old girl who presented with sickle cell disease and was in a chest crisis. And it becomes very hard for a student to decide which information to share when there's so much of it, and so they shared everything. They didn't filter it because it's too hard to figure out what to filter. And so they share lots of it. And they also invoked very rich descriptions. And here's an example from this student's case presentation. She has shallow breathing to minimize the pain. She was extremely short of breath, climbing even one staircase in their home and was finishing the stairs on her hands and knees. Now, you have a very clear picture of how sick this child is. But the student could have said she has dyspnea climbing stairs. They could have used a more medical frame, but they decided to give a very rich description. The pediatrician's response is really, all they did was ask clarification questions as the student went along this mountain of information. They didn't really try to teach much. They didn't engage much. It was almost too much to deal with. If they had wanted to deal with everything, they would have been there a very long time. The other case presentation, 14, not complex, actually a low complexity, and there wasn't as much information to present, easy to filter, and the student also invoked a very list-like presentation. Nasal flaring, trachea tight, intercostal indrawing, not what you'd call a rich description. Very medically appropriate terms, list-like, doesn't take a lot of airtime to do that. In this case, though, you may think, oh, low complexity, this is a great time for the pediatrician to teach a lot, but the pediatrician didn't. In some cases, I think they make choices that there's too little to teach. It's not a particularly interesting case. Maybe there are other things on their agenda they're not thinking about, and they don't choose to invoke that let's teach more broadly. So the pediatricians in a novice case presentation, when it comes to medical complexity, when it's highly complex, they tended to put little input in. There was too much to address. Whereas when it was a low complex situation, they either put little input, it's too little to address a poor teaching case, or they put in lots of input because they decided to teach more broadly than about that patient. The teaching strategies we saw invoked in the medical setting, they would use a number, pointing to an absence, like you didn't mention the antibiotic, pet topics, I love to talk about nutrition, quizzing the student, Socratic method, and modeling language. Here's an example of modeling language. No, we call that upper respiratory tract infection. That's what we call it. There is so much power in we. I'm a physician, and this is what we say when we're physicians, and you didn't use that language, you didn't get it right. So there's a real power to that kind of dialogue with the student. We also saw evidence of thinking as a doc, where the doc really looks at all this data and thinks about how reliable is the information, how relevant is it, how do I get information about the patient, and we see that demonstrated for the student. Here's an excerpt around accessing patient information. Pediatrician says, and it's really important to get the old chart and look at it and see what happened. So though during the novice case presentation, the student is not allowed to use the written record in the discussions, they must know it very well, and there is a clear importance given to the written record. The students, they've got to survive this educational path that they're on while looking after patients. And so some of the things that we saw medical students do was kind of strut their stuff sometimes, prove their competence to the doc. And they sometimes smelled that criticism was coming their way, and sometimes they just got criticism in their face, and so they had to deflect that criticism sometimes to deal with those critical moments. And also they sometimes sought the guidance of their instructors. Here's an example of deflecting criticism. Student 5, she had acute respiratory distress. I didn't mean adult respiratory distress. This is part of a very painful excerpt between the instructor and the student about what does ARD stand for. Does it stand for adult respiratory distress or acute respiratory distress? And I'll just tell you the student lost that discussion. But it was, here's the moment where the students try and defend themselves and clarify their position. The tacit messages in the medical, one of the ways in which we saw it, as the other moments that I've been mentioning, is the whole packaging of the case presentation. Who's your target audience? And the pediatricians, they have a real think like a doctor perspective. This one pediatrician in the interview said this: if you're presenting to a surgeon or a surgical resident, they're going to cut you off after 2 sentences. But if you're presenting to an internist or a pediatrician, we're going to listen to the whole story. Psychiatrists are going to listen to more than the whole story. Talk about a stereotypical invoking of different physician reputations. And that is shared with the students. Now, the students have a more thinking like a student perspective. Remember, they have to survive these instructors they have. The student says it's just that you have to cater your presentation to who you're presenting to. So it's that instructor in that moment. And they go on to talk about this. They got to survive that person. And all of their idiosyncrasies got to make it through that one. So they think of it more in surviving a student mode and not in the same perspective as the physician. The novice case presentation of these third-year students had a very diagnostic focus. 89% of the dialogue was about diagnosis. 10% was about treatment, and about 1% on communication. And so a question arises for us is, what implicit messages does that send regarding the importance of things like treatment and communication? Do the students think it's all about the diagnosis, which certainly seems very important. If you don't have the right diagnosis, you can't treat them. However, does it suggest that the little dialogue implies that treatment is all done one way, and once you have the diagnosis, that's the easy part? Does it suggest that the communication with the patient isn't particularly important, so we don't have to talk about it? There was also limited attention to the educational objectives of the pediatric rotation. in the case presentation. There were 9 objectives, and only 4 of them routinely were addressed. Here's an example of one of the objectives. Learn about childhood diseases. You'll not be surprised to hear that in 15 of the 16 case presentations, there were discussions about childhood illness. And so that one was routinely addressed. But what about the one that said, learn about the interplay between the child and the family? 1 case presentation. Was there any discussion about that kind of agenda? And so again, we don't see much of a focus on the patient agenda. So again, we ask, are these objectives that weren't being addressed in the case presentation, is there somewhere else in the pediatric rotation they are being addressed? Or does this rotation need to, the administrators look back at their educational objectives and see if they're realistic? And what implicit messages are we saying regarding importance of the ones we don't address? That the interplay of the family and the child isn't important? Could that be, in the presence of no explicit discussion, what the student concludes? Certainly, we saw that patient care and student education agendas coexist, and they compete. And that there are implicit messages being sent regarding care priorities. What's the importance of diagnosis versus treatment? What's the importance of the patient agenda? What's the importance of those educational objectives we said coming into your rotation that were important? And what's the messages behind the physician rationale of what we do, what we say, what we believe? I've talked to you about case presentations, but to bring us back to electronic records and to written records for a moment, the developers of electronic records may want to reflect on the socializing effects of the patient record, that written form, the implicit messages that it may create, and the interplay between case presentations and the patient record. We saw in optometry that the written record was absolutely pivotal in the case discussion. It wasn't in medicine. And we may want to reflect on the alignment of the case presentation and the written record. For example, how patient-centered is the case presentation? How patient-centered is the record? Those are some of the thoughts that we have currently about our data. Thanks for listening.
So we'll open up for discussion. I just want to make a comment. There's a similarity between optometry and specialist practice. Specialists do draw diagrams and refer to the record a lot. Optometrists are a kind of specialists. I would expect, though, in the general practice or family practice and maybe general internal medicine, more of this. But if you take a cardiologist, it's a lot more like an optometrist than like a family practitioner with regard to the use of the record and so on. So it might be interesting as you do this to also look at the specialist things. The other thing, back at the beginning that you said, remember you said that the optometry residents, whatever you call them, whoever was filling out the forms, I can't remember who was, they would fill out page 1, then page 3, then page 2. I mean, one could look at that as kind of a left brain phenomenon, like artists painting pictures, or maybe the forms aren't designed properly. Which is it?
Well, and that's a wonderful point, is that when you're designing a record, have you thought about the user and looked at, there's a real logic to why they do that, because the record is attached at the very top of the 2 pages, and it's a double-sided. So they fill out the first page, and then they open it and flip it over, so they can page 3 is right in front of them. And then they flip it once, and there's page 2. It's a beautiful thing to watch. Now, in the case presentation, there's a lot of going back and forth, but there's a logic, and so the developer probably knew a certain amount about the ergonomics of the page flipping and what kind of tests they needed to do in what order to look at it. So it is actually logical, but if you just took that record and looked at it without any knowledge, you'd probably start assuming we'd fill it out in order.
I don't know if you know from the deep, dark past, it took me a while to dredge up the name, Alvin Feinstein, is that, you probably know him, Paul. Wrote a book called Clinical Judgment, and we became famous for the introduced Venn diagrams. Feinstein wrote a little-known paper, or pair of papers, called Taxonomics 1 and 2 in the 1960s. And it was the science of forms design. And it's interesting what you're saying is physically it was easy to handle. But we also have a problem that the design of the forms or the screen affects not only what people complete, but forgetting whole areas of the screen if it doesn't fall into their, I guess, peripheral vision or whatever it is. But there is a kind of a science of design behind these things. I see what the thing was there. It was really flipping the pages.
Well, you raise a good point, is that the tool, whatever symbolic tool we're talking about, the case presentation or the record, it actually affects the user and the user affects the tool. There is that interaction going back and forth, and we all need to kind of think about that when we're kind of developing them.
Don, can I get your...
I'm going to make page 2, page 3 or something, but we're getting classy here. One thing, you may have said it and I may have missed it, but the impression I got, the optometry students were more interested in the patient agenda, or at least the optometry pair, if you will, the teacher and the student were more interested in the patient agenda than the medical people were.
They talked about it more.
Okay, and did you come to any conclusion why?
Well, optometry is as you know, a small and young profession, and it may behoove them to pay attention to the patient, who is quite a payer. As it turns out, for their assessments, they pay for their exams in a number of situations and more as time goes on. And they're paying for products, what we think of as treatments like spectacles and that. If you don't listen to your patient, they'll probably come to you once and not back again. So there is a certain logic to listening to the agenda of your patient that probably has been with us for a long time.
It's more market-driven.
There is a market, absolutely there. And is it that our youth as a profession has made us a little more able to look at some of the developing realizations in older professions that we actually might want to think the patient knows something and their agenda should be listened to? You can see that we struggle with that in optometry because we do try to shift them when they don't agree with us. But I think we have looked beyond ourselves and seen, there is this whole literature on patient-centeredness. How much are we paying attention? It's made us a bit reflective. Yes, Paul.
Yeah, thanks, Marlee. I think that was really interesting. This is just fascinating food for thought in a number of ways, including, as you've pointed out, the implications that this might have for how we think about the structuring of patient records. I'm wondering if you've done any of this work in the context of interdisciplinary teams and the structure and dynamics of communication in that context. And I think of that because I've spent a lot of my life working around geriatrics, where the idea of geriatrics is patients are complex. What do you do about that? You have interdisciplinary teams that need to function as these, collaborative units. And I've not often, but I have observed teams kind of struggling with how they should be communicating amongst themselves that would support this kind of communication that would be appropriate, that would be patient-centered, that would be oriented to the multiple individual goals of the patient and so forth. And so you would get these teams deciding that instead of having the doctor lead the discussion all the time, social worker today, nurse next week, and there would be this sort of shared discussion centered around the goals of the patient. And then, then one week a clerk would be there, and all of that would be thrown out the window. And it would get back into this very different sort of physician, instructor, clerk, student kind of dynamic. And all of a sudden it would be the clerk presenting the case. Mrs. Torgenrud is an 84-year-old woman with congestive heart failure, and totally in conflict with what the team has been sort of struggling to try to do as a different model. So, there's some elements of, team communication around that, and there's some elements of, the educational interaction being in some cases at odds with the actual practice model that a program was trying to implement.
You think just like we do, because Catherine and Lorelei and I noticed when we were looking at our data that there were many moments where the teacher talked about having to interact with another professional. In optometry, it would be the ophthalmologist. So we need to refer this patient out, and there'd be a discussion around how that would unfold. And we'd see discussions in the medical environment about, well, we're going to have to deal with those, the nurses and how they follow our instructions. And there'd be these little moments where messages are being sent about other healthcare professionals. And it got us quite interested in that. And so we said, hey, we better study that. So our more recently funded project that has, as we're finishing this one off and we've started on another one, another SSHRC grant, is looking at communication between professions or among professions. So we have 3 case studies that are unfolding, one where optometry and ophthalmology are communicating through written referrals and consulting reports, one where pediatricians are communicating with non-health professionals because they've encountered a case of suspected child abuse, so police and lawyers. And then a third case around a cancer treatment site where you have a multitude of different healthcare professionals and all of their politic and their hierarchy trying to play nice and look after the same patient. And so we too have that interest about looking at what are we teaching students about how to play nice with others, and how are these people with their different knowledges and skills and different beliefs and values working towards the common cause of a patient, or are they not? So we have a very similar interest. Okay. Ahar.
As we are in the process of evaluating and implementing an electronic medical record system, that is going to be implemented hopefully in the fall in the pre-clinic. Would like to see kind of a study that comparing the electronic medical record system against the paper record, and in terms of how the electronic medical record improve the clinician or the doctor-patient communication, how the workflow goes from page 1 to 4. Would it go like 1, 2, 3, 4,
Yes.
or 1, 3, 2, 4, whatever?
Yes.
How do you would you like to comment about this?
I think it's a very interesting area to study, and we've been talking about, because we see so much interaction going on, and we wonder at the precipice of creating things like electronic records, you have those kind of unique opportunities to say, okay, what's going on there, the interaction between the user and this tool, and are there opportunities to learn a little bit more about what may be happening, and as you say, kind of compare them to what we're more used to, at least in optometry, the written record. So I think it's a great area to explore. I think it's an important area, and it might help guide us as we're creating electronic records. Yeah.
One comment I make about that is Andre Kushnaruk, who talked here at the beginning of the year, pointed out that he's into usability, and he's found out that electronic records reduce the amount of information, including important information, and actually cause errors. So there's an issue here, a real serious issue.
Yes.
Marlee, I just wondered if the analysis that you've done, breaking your record, your interactions, your case presentations into quartiles, and then the sort of the learning one and the presenting one, and this complex patient versus a sort of more simple kind of patient, masked the effect of the duration of the presentation. Since we had no idea about the timing, was the didactic one, did that take longer? Was it shorter? Was the simple patient longer or shorter? I mean, so you see, I'm just worried about how long things were, and is there an interaction?
Certainly the range or the duration of case presentations really did range. You could have medical case presentations that unfolded and were done in 15 minutes, and then some that were a half an hour long. By us looking at it in a percentage way, we don't look at the length. You're absolutely right. So that one where it was a low complexity of a case and the student commands the airtime? Well, it's not a very long case presentation because it doesn't take them long to get through the information and that. So by looking at the way we did, we lose out on looking at the time in a more literal sense, how much time was taken. We are more interested in how they share time in a more global sense. But so we don't capture what you're saying. We just capture it in a more relative way.
Seemed like a very straightforward thing to do, though.
You know, no matter how we did it, there'd be pros and cons, and we decided, because there was a range, that proportionally made, in our view, the sense to do. But we did lose that as terms of the actual timing. You're right. Yeah.
You guys want to add anything to it here?
Just to say that in terms of electronic medical records, one of the things we're finding in a parallel study is that EPRs don't save that much time in terms of clinical work, at least the study we're doing in Toronto right now. And they're actually causing more work in terms of what are called workarounds in order to actually use EPRs. Now, these are old-style EPRs. The clinicians and the nurses and so forth are actually having to invent all kinds of paper ways of getting around the electronic medical records that are really fascinating in themselves. But in fact, my graduate student who's doing all this observing right now in Toronto, it calls them basically, it's a dog's breakfast in terms of the way EPRs are interacting with the clinical environment. And it's really something I haven't seen too much in the literature. There's this huge faith in EPRs, but to me, at least on the ground, it looks as if there's tremendous problems in terms of the design.
What's the type of workaround that goes on?
Well, for example, in order for nurses to actually use the electronic medical records, first of all, they pull off paper versions of that day's, of the record that they need to see for that day. And then in order to make it useful for themselves, they actually have to create lists. So they pull off the record, and then they pull out their own notepad, and they translate the information in the record into a list that they can actually use for their daily practice. And what's happening, too, is the multitudinous use of Post-it notes. Post-it notes all over records, and also pulling off the records on a daily use, putting all sorts of scribbles and notes all over them at the end of the day and destroying them. That's a common practice, actually, in many wards and hospitals, because some of the information goes back into the record in terms of electronic information, but a lot of it does not. It actually gets destroyed at the end of the day because it's too much work to actually put it back into the electronic record. So all sorts of interesting problems in terms of the design.
Yeah, if I could just add that, I think that's something that's been an interesting side point that you've illustrated, how, at least in the context of the medical student interaction, it's separated from the record. And I can think of legion examples of how that, as you've just described, the practice is separated from the record keeping and the information system, which is certainly going to do nothing to reinforce active use of electronic records in daily practice. So you've got this, in a sense, kind of artificial situation where you got to remember it all, or you have to write it down on something else in order to impress your instructor.
Yes.
At least in the more enlightened optometry environment, you've got, you haven't fooled yourself that this record is going to go away. You've actually got, that at hand, versus trying to simulate this kind of situation where you've got to do it in the absence of the record, or absence of the information, which is actually what you would presumably be using to make decisions about the case.
It may make optometry better suited for an electronic patient record than medicine because of some of the differences that we've talked about today.
Well, interestingly, Larry Weed, for the last 30 years, he's still hanging around, has been pointing out that he calls electronic records that guide and teach, records that guide and teach. That's what it's supposed to be. And rather than becoming, he calls it a medical legal dumping ground, which is what it is, it should be part of your work process. So what you're finding is this lack of parallelism between the work process and the record keeping, and the record keeping is imprisoning the work process. That can be overcome, but it means restructuring the record, whether you use problem-oriented, which is his thing, or something, along the lines of practice. Toronto General bought a multi-million-dollar nursing system back in the middle 1980s and had to throw it out because nursing practice was almost orthogonal to the way that system organized the records. And they had to send it back. It cost many millions of dollars, and they finally supposedly got something that was good, but it sounds like these problems still exist. I won't judge where your study's being done.
This one was more post-it note friendly.
Well, that's illegal. That's illegal to destroy them. If they're part of the record, that's illegal. I mean, that's now covered. So it's a very interesting situation. Any other comments or questions? Or I just want to just mention one odd thing at the end is that having done lots of grand rounds, that this is a game. This is a framework. It's a formula. And if you play the game well, if you do the formula, you always win. You always look good. And in some way, the same thing that builds arrogance builds confidence. That's what it's about. They're equal. But if you do grand rounds and you do them well, you do them according to the formula, they go well, and everybody likes it. There's nothing like that in computer science, or God knows in the arts. Or we don't teach people, and I don't know about optometry, we don't teach them structures for doing things well. Rather, we let them kind of freelance it and prose it. Well, interestingly, this creates a certain personality that creates huge confidence. You get in front of 500 people and talk freely. Most people at the university here are scared with 5 before them. So there's an interesting aspect of this, which is a training aspect. And I don't know how that applies in optometry. The only thing, have you probed whether or not the lack of time spent on these topics is an indicator of lack of interest in the topics? That seems like something that needs to be known.
And I agree with you, and we haven't really probed into that to see these gaps. What does it really say about? Go back and talk to these instructors and see how they value those educational objectives. Yeah. One data that I didn't talk about today is how optometry versus medical students approached uncertainty, clinical uncertainty, and they had different ways.
Oh, I completely.
And their professional identity really played out. One thing that you would have optometry students do is publicly own their limits in front of the instructor, even though they all agreed it was scary boo to do because their evaluation could be harmed. They would frankly own their limits. Medical students don't do that. They will showboat.
Sure.
Because it's part of the professional culture of what they're trained to do.
It's part of the dance that you do.
And physicians are doing, they get the referrals to them. Optometry is referring to physicians. And there's a whole, we have to consult with others who are professionally in terms of cultural capital, have more than we do. So we're more likely to own our limits publicly than the physicians did. And we thought that was kind of interesting.
Yeah, very interesting. Well, thank you very much. We thoroughly enjoyed your presentation. And I just want to make an announcement. Shirley is organizing a career night. And as I was listening, I realized, gee, we don't have any optometry companies coming into it, including the records company that P something or other. What is it called? B&B. B&B. Oh, those P. Anyway, those guys aren't going. The idea here is to introduce people in the industry to the potential of students for jobs, so they get to meet each other. It's on March 10th, and we might find it useful to talk to you about maybe inviting at least 1 or 2 optometry companies to it, including the information systems companies.
Now, if I can just sort of speak to that, it's March 10th from 4:30 to 7. The first hour will be very short, crisp little presentations on why selected people from our healthcare organizations and industry representatives have gone into certain areas of in terms of a particular company or why they chose that as a profession. So we're trying to have them mentor some of our students, and in addition, then following that, the students will be able to, and other participants will be able to mingle in a very informal setting for an hour of refreshments and just talking back and forth. So students can meet with all of these people, and they can meet with the students. So we're really looking forward to that event.
And our next research seminar
the next research seminar is by Pascal Picard. He's a computer scientist, and I just had the date. It's March the 9th, and he's an expert in artificial intelligence, and he's particularly looking at, Dominic, help me with me if I'm wrong, in the elder community.
Yeah, his area is intelligent assistive devices, including cognitive prosthetics. Really an interesting stuff. Yeah, there's a guy we're working with, Michaelidis, also in Toronto. They've done some really incredible work. And then I guess it's next week that John Glasser is talking?
No, it's February 23rd is our next Smarter Health seminar. John Glasser, those of you that went to the Future Symposium may have heard him speak already. Excellent speaker. He's one of the top CIOs in a healthcare organization's Partners Healthcare in the United States. So he'll be coming to talk to us about strategic IT areas of emphasis in healthcare organizations. So that should be a really great talk. And looking a little bit more forward, April, I know that Paul Stolle will be excited about this. We have...
he's speaking? Is that
we have Jim Anderson coming, and Dominic, just introduce us to Jim Anderson.
Jim is one of the premier people in the area of people and organizational issues and psychosocial aspects of computing. Written a book on that topic, an evaluation, a new book on evaluation, and one on ethics. He's an incredible guy. His work is extremely well known. I think he's near the top. It's Joan Ash and Jim Anderson are probably the two best known people in health informatics in that area, and Jim's agreed to come here, so we're real pleased about that.
What's the date on that?
Just give me a second. I think it's the 20th.
20th or 21st or something of April. I've got it down here. My book will be faster than
It's no, that's March, because this is in April that he's coming.
20th, probably.
20th. It's the 20th of April. And so he'll be giving a presentation, a more informal presentation on evaluation.
Yeah, that would be more of a scientific presentation in the morning. The objective there is to really go deeply into the stuff he's done in evaluation, which is quite substantial. The public talk will be more along the lines of the social context, the human context of computing. He's done a lot of work, and he'll even address, he's going to talk about ethics. It's one of his hot topics right now. So.
It's not that we're trying to avoid March as being a time for another seminar. It's just that we're negotiating for that speaker, but we really hope that it will be Susan Friesen, who will come and talk about supply chain management in healthcare.
Different kind of topic. Anyway, thanks everybody.
Thank you.